We are live, actually.
Right.
Good afternoon, everyone. Today is another Bariatric Friday. Today is January 14th. This is American Surgery Center. My name is Kemal Erkan. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing very well, Kemal. Thank you for having me. I'm always very happy to be part of Bariatric Friday.
Thank you for being with us. Dr. Irgau, we are going to discuss, last week we started our discussion with the type of bariatrics. So this is our third round. We are trying to keep things kind of in order, but in some cases with different issues coming up in healthcare, so we do make adjustments. So I do want to talk about a little bit the COVID impact on elective cases, and also the bariatric surgery process for those patients, what to expect, what they need to go through, and then what to expect after bariatric surgery. So I do want to open the session, but if today I don't want to do our regular intro, if you don't mind, just give me the brief background on CHRIAS and the surgery center, and we'll start with the discussion after that.
Sure, absolutely. So essentially, we are a practice that specializes in bariatric surgery. And bariatric surgery is weight loss surgery. And what we do essentially is treat people who are struggling with extreme levels of weight to lose weight effectively and become healthy. And we do a number of procedures to do that, and as well as education and evaluation of patients. We have a comprehensive program alongside the American Surgery Center that includes obviously the surgeons, it includes nutritionists, coordinators, and nurses as well. And together we are there really to help patients understand the importance of bariatric surgery, help them really understand whether they are candidates for bariatric surgery, help them choose the procedures that may be appropriate for them, and of course, most importantly, prepare them for that surgery, get them through the surgery safely, and then support them in the recovery as well in the long-term goals they have, not only to become successful when looking at the numbers coming down on the scale, but also with other important achievements, which is improvement in their health, including improvement in blood sugar controls, improvement of diabetes, improvement of high blood pressure, improvement of sleep apnea, and many other illnesses that are directly related to morbid obesity.
Sure. So, Dr. Irgau, we mentioned in so many different sessions what patient needs to go through, what we do, but as you know, these sessions are being watched by different people in different times. Just to kind of, and I'll help you with one of our slides here, kind of, if we were to kind of just summarize what they need to go through, what the process is, and then we'll go into the what to expect part of it.
Absolutely. So generally, patients are either referred by their primary care doctor or they self-refer themselves when they come to our practice seeking weight loss surgery. So obviously, the first thing that happens is a consultation with the surgeon. This is a one-to-one consultation. Often it's done through telehealth nowadays because of the restrictions imposed by the pandemic, but also it could be in person, where the patient comes in and in that encounter with the surgeon reviews the past history of the patient. They look at their current weight, the struggles that they've had with weight in the past, what they've done to try to lose weight in the past, and also what their comfort level is. What are they expecting, right, from that consultation? And very often they're coming, obviously, looking for weight loss surgery. And at that time, we really help them determine whether they are candidates for surgery. And obviously, candidacy for bariatric surgery depends on the weight of the person primarily, right? The person has to be at least about 100 pounds over their ideal body weight or have a body mass index of 40 or above. Sometimes even a lower body mass index can make a person a candidate for bariatric surgery if they have developed already certain serious illnesses related to weight, like diabetes, high blood pressure, or sleep apnea. So a body mass index of 35 sometimes can make a person a candidate if they have those illnesses. So once we determine that the patient is a candidate from that point of view, then we look at the rest of their history to see if there are other reasons why they may not be candidates for surgery. This is very rare, but it can happen. Regardless, at that time, the discussion is very extensive. we talk about the nature of bariatric surgery. We talk about the different types of bariatric surgery. We talk about, obviously, the potential complications of bariatric surgery, and there is a long opportunity for question and answers with any questions that the patients may have. Once we determine that that person is a candidate, then obviously we enroll them in the bariatric program.
So, Dr. Irgau, you mentioned diabetes, you mentioned hypertension. So, these are also major COVID-19 risk factors.
True.
Now, our patients do expect, we expect with the weight loss, some of these issues to be resolved in the following several months. Now, as you know, like one of the key terms that I use a lot is the perception. So there's the perception out there where obesity is a lifestyle choice. So it's not a disease. It's not. It's something. It's not. It's almost like it's not chronic. It's selective. So like all these, and then we are going through the pandemic. And you and I, we did one of these, one of our first sessions in the COVID-19, I think the 2020 sessions. What we were discussing is that our patients are at more risk during the time of COVID, during the time of pandemic, because they don't have just one illness, they have several different illnesses. Now, for our patients, if we can address a couple of different things. One is the situation with the COVID. Should I delay the procedure because there is a pandemic and my BMI is 47? Or if I continue with that, if I have my diabetes and hypertension, what to expect after the bariatric surgery from the actual surgical standpoint?
Absolutely. So, well, let's look at the general principles, obviously. In general, obviously, there are things we can do, each of us as individuals, to mitigate the effects of this pandemic. And you and I have talked about this. Obviously, now we do have things that we can do. We can get vaccinated, obviously, to receive protection, but also we can really change our behavior in a way that we minimize the exposure or the effects of COVID-19. This, in general, as health workers, we have to give this advice to our patients, and we've taken on this responsibility pretty well. Now, when it comes to our patients specifically, just because we specialize in the treatment of people who are morbidly obese, we really have a special responsibility in educating our patients on how much more dangerous it is for them specifically to be infected with COVID-19, right? Many studies have shown that one of the risk factors for serious illness or even mortality is higher weight, high blood pressure, diabetes, all conditions that our patients have. So in a situation like this, it really is very important for our patients to continue the precautions that they have to do, but also to continue to seek treatment for this foundational problem that they have, which is morbid obesity. So it makes very little sense for a patient to consider really postponing evaluation and treatment for weight loss surgery when the weight itself is such an important risk factor for the consequences for COVID-19, right? So what do we do to really minimize exposure? Of course, many of our visits are through telehealth, not only the visits with us, the surgeons, but as you have set it up in our network, Kemal, nutritionists now see patients through telehealth, psychologists through patients through telehealth. So many of the interactions are done through telehealth. So we should continue with them, of course. Now, patients who are ready to go to surgery, of course, there is some reticence when they see that hospitals are being filled up with patients that have COVID and so forth. And I understand. And of course, we have little control on what hospitals are doing. But when it comes to our surgery center, Kemal, it becomes one of the few areas where there is actually much more assurance that there is better control, because all we do is elective surgery on patients who have been screened by people who work there that are totally screened. So the safety level is actually very, very high. So if any surgery needs to be done from an elective point of view, the surgery center is actually better positioned to do that. right? So there is no reason to postpone the surgery at all in this setting, particularly for patients who are coming to our surgery center, Kemal.
So, so in the earlier session today, 2022, we started, actually, in the last couple of sessions, we started introducing a book. You were actually one of my first guests for our retreats at, what was that place on 52? Do you remember?
Oh, yeah, Mendenhall Hall.
Yes.
Yeah.
And I used to assign a book to the group, and then we would discuss. So we actually did introduce one of those books, 7 Habits of Highly Efficient People.
Mm-hmm.
And while I was going through that again, and I just showed this slide earlier with the some surgical cases being elective, and that was July 2020. Mm-hmm. And today is January 2022, and we are going through similar issues just because there are certain things that's not being done, being proactive, being end in mind, and several different things. And in some cases, we may not be the decision makers, or we may not be the policymakers. We may not have the big impact like the hospitals have, but they knew this was going to happen. They kind of benefit from this. So we want to kind of make sure that our patients understand our surgery center is designed. We made adjustments to address these issues, limit the number of people that we operate, and also understand that this is not an elective surgery. It's not like elective is very clear. Elective, like you elect to do something, versus this is necessary. In some cases, the urgency is there. So now I kind of mix our session with what to expect after the surgery with the COVID and the elective surgery. And there was a reason for that. Now, our typical patients do have these issues in red.
Yep.
Now, which clear mind can tell me that these patients who have these problems may need to go through the elective surgery for bariatric, if the bariatric is, if the morbid obesity is the root of all these problems. Now, this patient actually is a 348-pound with high blood pressure, high cholesterol, heartburn, sleep apnea, diabetes. When this patient gets COVID, this patient having a severe reaction to COVID or severe experience with COVID is highly likely. And in fact, this patient may die. So those patients that we see who are dying from COVID are patients like these. Right. So how can you say, like you don't obviously, how can someone say that this is an elective surgery for this patient? This is an urgent surgery for this patient, right? So, but let's talk about this patient outside of COVID. So this patient, when they go through the bariatric surgery, what happens if they have high blood pressure? In this case, this patient did have high blood pressure, did have sleep apnea, and did have diabetes. What do we expect after the surgery?
We expect improvement in those conditions, because the root cause, as you said, is the weight. And after the surgery, they start losing weight, and they start losing weight efficiently, right? So many of the medical problems that are associated with weight start to improve. Let's start with high blood pressure, for instance, right? We do educate patients. We tell them that their blood pressure may start improving and going down, but sometimes, obviously, they don't remember everything, and we get calls in the office, or when I see them in their first postoperative visit, they say, "Oh, I was trying to get up from the chair the other day, and I felt dizzy," right? And I know immediately what has happened. What has happened is that patient had high blood pressure. They were on medication for high blood pressure. They've had bariatric surgery. Their high blood pressure now has improved, but they're still taking medications, which means their blood pressure now starting to go too low. So the first thing I tell them is, have you stopped your blood pressure medication? Because you may be cured from your high blood pressure. Mm-hmm. Now they say, no, I'm still continuing. Then I tell them, look, you have to call your primary care doctor today and let them know that you're losing weight, and you may not need your blood pressure medication, and you're feeling dizzy, and then they will be able to address that with you. So in fact, improvement in blood pressure, sometimes we'd see within days or weeks after the bariatric surgery. The same thing with diabetes, Kemal. The same thing with blood sugar, right? Patients who experienced very high blood sugar levels. In fact, you and I see them very often before surgery when we check indicators of chronically elevated blood sugar, something called the hemoglobin A1C, which is up in the roof very often, right? After the surgery, it starts coming down. And if they were taking medications for diabetes, we want those medications to start being reduced because we don't want their blood sugar to bottom down, right? So diabetes improves. What else improves? Sleep apnea. Patients who have sleep apnea, who've been using a CPAP machine in order for them to sleep safely, now the sleep apnea improves because they're losing weight. A lot of the fat around the back of their mouths, around their neck starts disappearing. Flow of air, flow of oxygen when they are asleep is much improved. There is no obstruction. So they don't need a machine that pushes the air forcefully like the CPAP machine, right? So they can get rid of that. They tell you immediately, I'm sleeping a lot better. I feel well rested. I don't feel like napping anymore, right? Because of the improvement in sleep apnea. Similarly, we see improvement in high cholesterol. We do see improvements in heartburn, although that improvement in heartburn is not universal, and it may depend with the type of bariatric surgery they've had. Certainly, if they've had gastric bypass, heartburn disappears as well. If they've had the sleeve gastrectomy, not necessarily. Sometimes it improves and sometimes it may not. But clearly, what you're pointing out, Kemal, is that you are saying this patient who is walking around with life-threatening illnesses on their back, right, cannot be told that an intervention that would remove these life-threatening conditions is an elective procedure that could be placed on the back burner until there is room or there is time for them. This is a discussion that you and I have highlighted really very early after the beginning of the pandemic, when we saw that hospitals that have slowed down an elective surgery, when they were starting to accept elective surgeries, and they were choosing at which surgeries they should go first. They were saying, oh, well, maybe we should do knee replacement surgery, maybe hip replacement surgery, or gallbladder surgery, but bariatric surgery, weight loss surgery, cosmetic surgery, plastic surgery, those can wait, right? And we, jumped up in arms and said, look, you cannot put bariatric surgery at the same level as a body modeling procedure or plastic surgery. This is a life-saving, this is a critically important procedure that should be placed in the ranks of cancer surgery because of the life-threatening conditions that obesity carries with it. But why do we have to even raise this issue, Kemal? It is because there is this inherent bias in thinking that people who suffer with weight is almost like their fault. The reason they are overweight is because they don't have willpower to overcome this, right? There is nothing more false than that, as we firmly know now, because weight is related to biology. Of course, the society we live in, the environment is really importantly influencing this importantly. But the bottom line is that when your weight is 348 pounds, Kemal, and you are 5'5", 5'6" in height, there is no way for you to be able to lose that weight by yourself just with willpower. At least the vast majority of people cannot do it persistently. They need help. They need medical help. They need bariatric surgery, which is the most effective way for us to treat this condition currently.
So what we are saying is we can actually help these patients greatly, right? So we actually, from the surgery center standpoint, from the CHRIAS standpoint, with the multidisciplinary program in place. Now, what I want to tell you this morning, as you know, with our 10 a.m. daily case conference, we have 8 a.m. ACO case conference, and some of the ACO patients, well, some, meaning like half of the ACO patients have obesity-related diagnosis, and more than 70%, I may be off with the numbers a little bit, more than 70% of those patients, they refuse to follow up with the bariatric surgery consult, even for the nutrition consult. Now, they can benefit the greatest with this surgery. with this intervention. Yet there is still big pushback from the patient standpoint. Do you think that's the understanding of the surgery itself, or they're still like maybe afraid of getting the surgery? This is covered by Medicaid. Like, it's not like some plastic surgery type. My hair wasn't covered by my insurance. I paid out of pocket. So, but this is covered by Medicaid, and patients don't pay anything. Why would there be a big pushback from the patient standpoint? Because sometimes, as you know, like, I may get a little bit emotional because the ACO group doesn't know exactly what's happening in our bariatric case conference, so they don't know why I get so excited when something happens. Like, we can't help this patient. This is the patient that we are looking for, who can benefit the most from this surgery, because they have like 5 other illnesses. So Medicaid pays for it, commercial insurance pays for it, Medicare pays for it, and yet we are still not able to get them to see their surgeons or their nutritionists.
Yeah, there's no question, Kemal. We see that very, very often. I think the number one reason is the stigma that society has placed on obesity. This stigma is so strong that for many patients, the struggle with weight is a private struggle. It's a silent struggle, right? They don't bring it out. Of course, everybody sees it, everybody knows it, because you are carrying the weight. And yet, coming out and telling people that you need help and effective help is something that is not encouraged by society, because getting help, asking for help, is interpreted as failure, is interpreted as lack of willpower. In fact, very often, when I do consults, Kemal, I hear patients tell me that they've heard about bariatric surgery even years before, and they really refused to come and seek that help because they felt that they were not strong enough themselves. That's why they were failing. They really did not understand that what they were fighting against was their own biology, right? A biology that is programmed to favor weight gain as opposed to weight loss, right? It is far easier to gain 5-6 pounds over a weekend, Kemal, than it is to lose those 5-6 pounds on a similar period of time. Our body treats these two things differently. So you are fighting this entrenched biology that is set up to defend obesity. There are reasons for that, and we've raised them, but that is what it is. So patients feel as if they are failing, as if they don't have strength themselves when they come to seek help. It takes them a long time. And then on top of that, there is discouragement. If there may be even health workers who don't really encourage patients to seek bariatric surgery, even in this day and age. So all that misconception really discourages patients. And sessions like the one that we're having, Kemal, are critically important in telling people that seeking help is actually not only okay, but absolutely necessary for their long-term health interests.
Well, the silver lining here is with the pandemic, we have digital health, we have telemedicine. Yep. So part of the part of the reason that I'm a little bit unhappy about this more than usual is because telemedicine makes it so much easier for patients to be seen. It's safe. They don't have to leave their home. They can just they can be in their office as long as they have some privacy there. And we are the one of the first groups as a network who actually who took the telemedicine to a next level. So we just take it and run with it. And I don't know if patients are kind of not seeing this as a big benefit. So I want people to really see what we are offering here. So for us to be able to do these, now people are going to say, well, are you guys looking for patients? Well, no, we couldn't finish our case conference with the number of patients that we had. So there were March is still not done. So it's not about lack of patients. So we just started our March patient this morning. So the 4 days was because there were so many patients. Right. So what I see is compliance, patient not understanding, especially from the ACO program. We send the patient to nutritionists and to bariatrician, to the bariatric surgery, and then there's a patient refusal. I'm like, why would the patient refuse? So this is the only solution that they have. So now that's why I want to kind of talk about the benefits of the surgery, and with these different illnesses, comorbidities that we have, it's the only way that they can actually solve these problems. So I'm hoping that we can reach out to more people, and there will be that we can reach out to more people, and we can help more people. That's kind of like our goal. So,
Absolutely. Go ahead.
Anything you would like to add?
Yeah. So essentially, the point is that I do, to some extent, have having really worked with patients who struggle with morbid obesity for 20 years now, I do understand why there is reticence very often, right? Particularly if people have heard, about complications and other things about bariatric surgery, right? There is no denial surgery can have complications, but it is also very clear that bariatric surgery has reached an extremely high level of safety, particularly in programs like ours, Kemal, where the preparation level, the selection of patients, the actual surgery itself has reached really levels of safety now that make bariatric surgery comparable to hip replacement surgery or gallbladder surgery very often. And as you know, particularly in our program, the vast majority of our patients are done in surgeries are done in an outpatient setting, right? Patients go home the same day after procedures like sleeve gastrectomy and gastric bypass. And that is because we have been able to reach levels of safety which are really unprecedented, right? So this is important for us to tell them that. It does not mean there is no potential for complications like any treatment, like any surgery. There is potential. But really, the levels of safety that have achieved are so high right now when you look at the benefits of surgery and you compare them to the risks of not having surgery, right? Of the risks of staying overweight, the risks of having high blood pressure that continues to worsen, the risks of having diabetes that continues to worsen, the risk of having sleep apnea. All those risks, although they are risks that are looked at in the medium and long term, when you looked at them, they are really far worse than the immediate risk of surgery. As I say, surgery has become very, very safe nowadays. Having said that, it is important that patients are comfortable with this. That is why we don't see a patient for consultation and do surgery the next week, right? The interval time between consultation and the surgery can be 2 months, 3 months, and sometimes even 6 months, which means there is a long time for people to really understand, become comfortable with the idea of bariatric surgery. So that first consultation, very often, they shouldn't take it as, oh, I'm going to have surgery immediately. No, that first consultation is actually an introduction to the program where the person is enrolled in the program, and then they will have several months of interaction with different specialists where their knowledge and understanding will be expanded even more.
Definitely. Now, the good news is our providers are watching, because I'm getting messages. So they're telling me that they do tell the patients to follow up with the nutritionist and follow up with the bariatric surgery. So, and then they're seeing patients. So that means maybe
that's wonderful.
They're watching. So I actually am getting messages from 4 different offices. So that's good. That's good. So again, when we identify the problem in the clinical settings, we are looking for what's the main cause of the problem, like the problem that we're having, and if the resolution is relying on solving the obesity, morbid obesity, in some cases, surgical intervention is the only option. And that's why we are here, and we have the most expertise and best program probably in the country. And we are proud of that. Our patients are happy. We want to help more people. We made all the adjustments related to COVID Our surgery center is probably the safest place for anyone, not just for the patient, honestly, probably the cleanest place on the earth. So, well, please reach out and follow up with your appointments. Reach out to us with questions. We are here to help. And Dr. Irgau, thank you for joining me and thank you for being with us. We'll be back next week and we'll see you guys soon.